Welcome. Today we're diving into the world of Modic changes, those subtle but important alterations in the vertebral and plates that show up on MRI scans. These changes are often found in people with low back pain, but what do they really mean? In this video, we'll explore the types of Modic changes, their prevalence, and how they relate to other spinal conditions. We'll also look at the latest research from an Iranian population, offering fresh insights into how these findings might affect diagnosis and treatment. Let's start by understanding what Modic changes are and why they matter in spinal health. Modic changes refer to specific alterations in the vertebral and plates and adjacent bone marrow, visible on MRI scans. First described by Modic and colleagues in the 1980s, these changes are categorized into three types based on their appearance on MRI. They're important because they often accompany degenerative spinal conditions like disc degeneration and herniation. Understanding Modic changes helps clinicians interpret MRI results more accurately and may influence treatment decisions for patients with chronic low back pain. There are three main types of Modic changes, each with distinct MRI characteristics and underlying pathology. Type 1 indicates bone marrow edema and inflammation, appearing as low signal on T1 and high signal on T2 MRI images. Type 2 is characterized by fatty infiltration, showing high signal on both T1 and T2. Type 3, the rarest, involves subchondral bone sclerosis and appears as low signal on both T1 and T2. Sometimes mixed types can occur, and type 1 may progress to type 2 or 3 over time. Modic changes are more than just radiological curiosities. They're linked to various spinal pathologies and may influence patient symptoms and outcomes. However, the exact associations between specific Modic types and other spinal conditions remain unclear. That's why researchers are keen to study their prevalence and relationships with factors like age, gender, disc degeneration, herniation, and spondylolisthesis. By clarifying these links, clinicians can better predict disease progression and tailor treatments for low back pain. Recent retrospective study in Iran analyzed lumbar MRI scans from 1,350 patients with low back pain. The goal was to determine how common Modic changes are and how they relate to other spinal findings and demographic factors. Patients with tumors, infections, fractures, or prior lumbar surgery were excluded to focus on degenerative changes. The study used standard MRI protocols and classified Modic changes into three types based on established criteria. MRI scans were performed using a Philips Ingenia 1.5T scanner, with patients in a supine position. The imaging protocol included sagittal T1 and T2 turbospin echo sequences from T12 to the sacrum, and axial T2 images from L1 to S1. These sequences help visualize both the vertebral and plates and the intervertebral discs, making it possible to identify Modic changes and assess disc degeneration, herniation, and spondylolisthesis. Among the 1,350 patients screened, 316, 23.4%, showed Modic changes on MRI. The average age was about 53 years, and women made up 61% of the group. This female predominance is notable and may reflect broader trends in musculoskeletal disorders, particularly in populations where women often perform physically demanding household tasks. Type 2 Modic changes were by far the most common, found in nearly 89% of patients with Modic changes. Type 1 was much less frequent at about 10%, and Type 3 was rare, seen in just 1.3%. This distribution highlights the predominance of fatty infiltration type 2 in degenerative spinal conditions, especially in older adults. Modic changes were most frequently observed at the L4, L5, and L5S1 spinal levels. At L5S1, over half of the cases showed type 2 changes, while type 1 and type 3 were much less common. The L1, L2 level had the lowest incidence of Modic changes. This segmental pattern aligns with the areas of the spine that bear the most mechanical stress and are most prone to degeneration. Although women had a higher prevalence of Modic changes, statistical analysis showed no significant association between sex and the occurrence of any Modic subtype. Both men and women exhibited all three types, but the trends may reflect differences in physical activity or occupational exposure. These findings suggest that gender alone does not determine the risk for Modic changes. Age played a significant role in the distribution of Modic types. Patients with type 1 changes were younger, averaging about 47 years, while those with type 2 and type 3 were older, with means of 53.5 and 63.5 years respectively. This suggests that Modic changes may evolve with age, progressing from inflammatory type 1 to fatty type 2, and rarely to sclerotic type 3 state. Disc degeneration was present in about 63% of patients with Modic changes. While initial analysis suggested a link between Modic type 2 and disc degeneration, this association did not remain statistically significant after correcting for multiple comparisons. This highlights the complexity of spinal degeneration and the need for careful interpretation of MRI findings. Disc herniation was the most common structural abnormality, found in nearly 87% of patients with Modic changes. Although Modic type 1 initially appeared to be associated with herniation, this relationship was not statistically significant after adjustment. The high rate of herniation underscores its role in low back pain, but suggests that Modic changes are not exclusive markers for this condition. Spondylolisthesis or vertebral slippage was less common, affecting about 10% of patients with Modic changes. The study found no significant association between any Modic type and spondylolisthesis. This suggests that while both conditions can coexist, they may arise from different underlying mechanisms or risk factors. Study used robust statistical methods, including the Kolmogorov-Smirnov test for normality, Mann-Whitney tests for group comparisons, and Bonferroni correction to control for multiple comparisons. This careful approach ensures that reported associations are not due to chance, but it also means that some initially promising links may not reach statistical significance after adjustment. Representative MRI images help illustrate the differences between Modic types. Type 1 shows bone marrow edema, Type 2 reveals fatty infiltration, and Type 3 displays bone sclerosis. These visual cues are essential for radiologists and clinicians to accurately identify and classify Modic changes during routine MRI interpretation. Study segmental analysis revealed that Modic changes are most prevalent at the lower lumbar levels, particularly L4, L5, and L5S1. These regions are subject to the greatest mechanical loads and are common sites for degenerative changes. Understanding this distribution helps clinicians focus their attention during MRI review. While women had a higher overall prevalence of Modic changes, they were more likely to have Type 2, whereas men had a slightly higher proportion of Type 1. These trends may reflect differences in physical activity, occupational exposure, or even genetic factors, but the study did not find statistically significant differences between sexes. The progression of Modic changes with age is a key finding. Younger patients tend to have Type 1, which may represent an earlier, more inflammatory stage. As patients age, Type 2 becomes more common, reflecting fatty replacement of bone marrow. Type 3, involving bone sclerosis, is rare and seen mostly in the oldest patients. The study used the Fuhrman grading system to assess disc degeneration, focusing on grades 3 to 5, which represent moderate to severe disease. This standardized approach allows for consistent comparison across patients and helps clarify the relationship between Modic changes and disc health. Disc herniation was evaluated according to the American Association of Orthopedic Surgeons criteria, including all forms such as protrusion, extrusion, and sequestration. This comprehensive assessment ensures that all clinically relevant herniations are captured in the analysis. Spondylolisthesis, or slippage of one vertebra over another, was identified by MRI findings of facet joint effusion greater than 1.5. This method helps distinguish degenerative spondylolisthesis from other causes and ensures accurate classification in the study. The study applied Bonferroni correction to adjust for multiple comparisons, reducing the risk of false positive findings. While some associations appeared significant at first, they did not remain so after correction. This cautious approach strengthens the reliability of the study's conclusions. Findings of this study are consistent with previous research showing a high prevalence of Modic changes in patients with degenerative disc disease. However, the lack of strong associations with disc herniation or spondylolisthesis after correction highlights the need for further research to clarify these relationships. For clinicians, recognizing Modic changes on MRI can provide valuable information about the stage and type of spinal degeneration. However, the lack of strong statistical associations with other conditions means that Modic changes should be interpreted as part of a broader clinical picture, not in isolation. It's important to note the study's limitations. Its cross-sectional retrospective design means it can't establish causality. The lack of follow-up data and the absence of certain confounding factors like BMI or occupational history may also affect the findings. Future studies should address these gaps with prospective longitudinal designs. Previous research has suggested that factors like BMI, smoking, and occupational physical load may influence the development of Modic changes. However, in this study, these variables were not controlled for and their impact remains uncertain. This highlights the multifactorial nature of spinal degeneration. In many cultures, women perform a significant amount of physically demanding household work, which may contribute to the higher prevalence of musculoskeletal disorders, including Modic changes. Studies in Iran have shown that more than half of housewives experience such disorders, emphasizing the need for ergonomic interventions. Interestingly, Modic changes are not exclusive to people with back pain, they can also be found in asymptomatic individuals. Prevalence rates in healthy populations range from 0.5% to nearly 50%, suggesting that Modic changes alone do not always cause symptoms. The impact of Modic changes on clinical outcomes is still debated. Some studies suggest that their presence may predict slower recovery after certain spinal surgeries, while others find no significant effect. This uncertainty underscores the need for individualized patient assessment. Systematic reviews have found that Modic changes may negatively affect recovery after discectomy but could be associated with better outcomes after total disc replacement. The type of Modic change and the surgical procedure both play roles in determining prognosis. Type 1 Modic changes are thought to represent an active inflammatory process in the vertebral end plates. This stage may be more responsive to anti-inflammatory treatments, but it can also progress to the more chronic fatty type 2 stage over time. Type 2 Modic changes indicate fatty replacement of bone marrow in the vertebral end plates. This stage is considered more chronic and is the most common type seen in older adults with degenerative spinal disease. Type 3 Modic changes are rare and involve sclerosis or hardening of the bone beneath the end plate. This stage is seen mostly in older individuals and may represent the end stage of the Modic change spectrum. Modic changes can evolve over time, with type 1 sometimes progressing to type 2 or even type 3. In some cases, Modic changes may resolve entirely. This dynamic nature reflects the ongoing processes of inflammation, fat deposition, and bone remodeling in the spine. The development of Modic changes is influenced by a combination of genetic, metabolic, and environmental factors. While disc degeneration and mechanical stress play major roles, lifestyle factors like physical activity and body weight may also contribute. For patients, the presence of Modic changes on MRI can be concerning, but it's important to remember that these findings are just one piece of the puzzle. Clinical symptoms, physical examination, and other imaging findings all contribute to a comprehensive diagnosis and treatment plan. Study's authors recommend further longitudinal research to track the progression of Modic changes over time and to clarify their clinical significance. Integrating imaging with biochemical markers and patient outcomes could lead to more personalized management strategies for degenerative spinal disorders. Sum up, Modic type 2 is the most common subtype in patients with low back pain, especially in older adults and women. While Modic changes are frequently seen alongside disc degeneration and herniation, strong statistical associations are lacking after rigorous analysis. Spondylolisthesis does not appear to be linked to Modic changes in this population. Clinicians should view Modic changes as important radiological features that may reflect underlying spinal degeneration. However, these findings should be interpreted in context alongside other clinical and imaging data to guide patient management effectively. For patients, understanding that Modic changes are common and not always linked to severe symptoms can be reassuring. Open communication with healthcare providers about MRI findings and treatment options is key to managing expectations and improving outcomes. The future of spinal care lies in integrating imaging findings like Modic changes with clinical assessments and patient-reported outcomes. This holistic approach can help tailor interventions and monitor disease progression more effectively. MRI remains the gold standard for detecting Modic changes and other spinal abnormalities. Its ability to differentiate between types of tissue changes makes it invaluable for diagnosing and monitoring degenerative spinal conditions. As research advances, personalized medicine approaches may allow for more targeted treatments based on a patient's specific Modic type, genetic background, and lifestyle factors. This could improve outcomes and reduce unnecessary interventions. Conclusion: Modic changes are common findings in lumbar spine MRI, especially in patients with low back pain. While they often coexist with other degenerative changes, their clinical significance remains an area of active research. Ongoing studies will help clarify their role in diagnosis, prognosis, and treatment, paving the way for more effective and individualized spine care.